certain amount of education has to be carried out, but I think all three of these gentlemen, again, through their fine presentations, have been able to find the right way to get people to engage into their endeavors. So maybe, Bob, since Steve presented your group as the high-performing group that we all know it is, and we admire that, how do you get your docs engaged to perform at such a high level?
Yeah, great question. Really, I think, as was mentioned, we see this as a team effort. As a fully integrated group, we're all in it together, so we have divisional and operating teams at each of our divisions: medicine, family medicine, peds, and OB-GYN, and then our specialty division. And those folks all share best practice readily because, again, we are all in it together. But it goes beyond that. It's our teams of our support folks as well, so that if we have a new initiative, say, to improve our HEDIS scores, the practice managers meet separately, the senior nurses meet separately, the receptionists meet separately at monthly meetings, and all are getting the same initiatives put forth, so that when a doc comes back to an office from a team meeting and says, hey, we're going to do this, the nurses say, yep, we talked about that in our group, and here's the tools to help do that. The practice manager says the receptionists are ready to take the calls about that, and it happens in a way that is a team effort instead of coming back on deaf ears with a system that then falls off on the shelf. So I think that a big part of our secret to engagement is the team approach.
Any comments from the other two about within the hospital or the academic center? I mean, obviously you have a little more clout. If you want privileged as our hospital, you're going to do this, or if you're employed, but certainly there's got to be more to it than that.
So if you think that people do what you say, that's. So I think the key is really what Bob said. What we've tried to do is put leadership at each of the practice levels. So we have a physician one physician that's a leader at each one of the clinics. We have 124 clinics and a manager at each of those sites, and they're engaged in their responsibility is to engage the physicians in the initiatives of whether they're quality, whether the practice. We also have invested a fair amount of leadership training in those physicians, both in understanding lean, understanding quality assessment, and safety training. So that's what how we've approached it. But you need on-site at the practice level leadership in order to engage everybody.
Thank you. Sam, any comments on?
Well, I think sort of as I said in my talk, making rules and doing education is a very ineffective way generally of getting stuff to happen. We try it all the time, emails and various stuff sent to the offices, but I'm not sure it's that effective. The things that seem to work the best are the things that make the right thing happen. So make it easy to do the right thing. If something becomes less time consuming to do it, people will generally do it. I think providing hospitalists, which pretty much every hospital has done now, has been a great thing for those folks that don't want to come to the hospital, and that's a smaller group of physicians that it's easier to get equanimity of practice there, and then just hardwiring things in the system like you saw with the heparin, just making it that easy so that it's really hard to do the wrong thing and easy to do the right thing. Those are the things that we find work the best.
And I kind of thought those would be the answers, and I think, again, from being in this role for a couple of years, it's one of the things I see. I think our average practice in UP, which as you know is 2/3 specialists and about 1/3 PCPs, our average practice is about 2.4 docs per practice, quite a few solo practice docs, and then some pretty big, larger groups that bring that number up a little bit. So again, stressing the importance of, and again, I knew what they were going to say because I've studied at least Bob's group for a couple of years, and that's having those champions at the practice level or the office that are going to take charge and bring that kind of idea of population management. Although I have to say, I've been looking at IHA for probably 4 or 5 years and spent a lot of time with Bill Folletti, their administrative leader. But these guys were doing this before population management became a buzzword, and I think that's why that's how they've leapt out to such a lead on everybody. And I would hope we can follow some of these comments to kind of catch up to where they're leading us. Questions about PCMH? Any thoughts on PCMH, its effect on safety, maybe, Sam, within the hospital? Do you see any correlation between the docs that are PCMH? Do you even know which ones they are? Or maybe a lot of them aren't even coming to the hospital, or certainly outpatient metrics, quality-wise. Any comments from any of you?
Honestly, we haven't looked at that, Mike, and I can't answer because we just haven't looked at its effect on safety.
Quality metrics, outpatient, I mean, you guys both are very well penetrated with PCMH.
Well, I think that the principles of patient-centered medical home are important I think they're important in preventing readmissions. So if you looked at our Medicare demo project from 2005 to 2010, we were able to save Medicare $47 million. But the main area that occurred was a dramatic reduction in readmissions associated with our dual eligible population and our end-stage renal disease population. And when you look at the Dartmouth Atlas that was published in 2010, only U of M and Northwestern, the two academic centers that saw a statistically significant decrease in readmissions. And part of that, and when we segment out that information, we find that it was the PCPs that were in our system and had PMH or PCMH certification that seemed to be the areas where it made a difference. Now, whether it was exactly due to that, there was, whether that's causal or not, I don't know. But I think that we did see significant improved coordination and reduction in readmissions and also ambulatory sensitive admissions.
Bob, any comments?
Yeah, all of our offices are PCMH designated and take that very seriously to make sure that we keep that accreditation by carefully monitoring and seeing where we have needs within practices. And we use a system-based approach across our practices to implement the principles of data availability for clinical decision-making for complex and moderate care managers, which we're in the process now of implementing across our practices. And we also twice a year measure patient satisfaction and use the information we get from that to feed back to say where and how can we better serve their needs so that the patient-centered part of patient-centered medical home comes through loud and clear on our visions and missions for each given year.
Thank you. Sam, you touched a little bit on cookbook medicine, but I think a large part of some of the issues we have, a lot of things up there on when to redo an EGD, a colonoscopy, there are no standards or guidelines written. The variation amongst the network can be huge. So inpatient or outpatient, comments on reducing variation but not to a cookbook, so tight that it's a cookbook. I mean, and maybe some successes you've had from safety or just performing so well as an outpatient group.
No, it's a great question, and I think whenever I think about this, the stuff where there is clear-cut evidence, I think we're obligated to do that at 100%. So, an example would be antibiotics to prevent surgical site infections. There's great evidence that if you give that within 60 minutes of the incision, it prevents it. And so, the goal has to be 100% on that, and there can't be any variation. For some of the other things where, if all other things being equal, I think we should go for the lower cost alternative. If there isn't evidence to say that the higher cost is better. But most of our work is really focused on the ones where there is clear-cut evidence that, this way is better than that way. And again, our best successes have been where we've been able to somehow hardwire the practice into something that makes it so easy to do that you're just not likely to do it a different way. If we make it harder to do, the success rate goes way down.
Dave or Bob, any comments?
Yeah, well, I think where we've approached it is even though there may not be complete evidence on how we should practice, we think that in order to improve, you have to have a standard that you all agree to practice by, and then if we want to make improvements, we have a base from which to go from. So we have within our group, we have a group called Guides, which are guideline development, and that was actually started in '96, and we attack problems that occur across subspecialties. So if you look at spinal infections, you're going to get what the infectious disease, what the neurosurgeons say, and what the interventional radiologists say are problematic, and you need to get them in order to deliver the best care. We need to be on the same page as what we, even though we may disagree initially, we come to some consensus of how we're going to handle these situations. So we're not arguing about whether a second biopsy is necessary or whether antibiotics should be withheld because neurosurgery say they should be given right away, infectious disease they should be withheld. but we need to come to some consensus on these, what I would call difficult patient management problems across our enterprise. So we do that both inpatient and outpatient, back pain, other sets of conditions that are high cost, but more, I think, clinical problem areas. And a lot of that comes out of, unfortunately, we see it in our quality review of adverse events, that we have a problem in agreement on how we take care of patients.
Yeah, I think that's a critical question, and it often comes down to whose evidence. And of course, when we look at our organization of trying to decrease variation, because you can find oftentimes conflicting evidence within the medical literature, is vetting that through our committees. We have a clinical quality improvement committee that's been with us for all of our existence, 18 years, and just 3 years ago implemented an evidence-based work group that specifically looks at areas of controversy, and also recently started a monthly journal club, which is well attended and takes areas of controversy. Recent ones have been on PSA screening, osteoporosis screening, anticoagulation and AFib, and testosterone administration, and look at the literature and talk about that, and then feed that back to the evidence-based work group or the clinical quality improvement committee, so that we can then embed tools within our EMR that will help make the right thing the easy thing to do. The other key to that, I think, is you can't change what you can't measure, and we do carefully try to monitor where people are, and then feedback through our operating and divisional teams about where we stand with respect to each other, and how we can then share best practice. Again, not in a punitive way, but to be able to say, why is it that so-and-so is ordering 3 times as much high-tech radiology as so-and-so? And in what areas? Is it ortho? Is it neuro? Is it in what areas? And then we can learn from each other and get to a best practice state.
Last question I have, and it's probably a difficult one, but I think to achieve the success that each of you have achieved in your day-to-day responsibilities, culture trumps strategy every time you hear that, and it's kind of a difficult question, but the answer I want to hear, I want to see if you'll give me, but where do you start with building that culture for transformation of healthcare? And, again, you've had real success safety-wise within Beaumont, outpatient, inpatient, and Ann Arbor. What do you find to be the most significant igniter of that creating culture that you need to?
So I don't know.
This is. I'm going to pick Bachelor 1, 2, or 3 based on this question.
I don't. So I think Jack Welch once said in one of his books, I don't remember which one, that it takes about 2 years for every level of hierarchy in an organization to change the culture. That being said, there was also we have become a lean organization, not lean trained. And one of our lean trainers is John Shook, who's a engineer, teaches at the engineering school, and he was involved in the NUMMI plant. I don't know if you know of NUMMI in Oakland, California, where they took the Vega plant, the worst performing plant in GM, and they had a joint venture with Toyota, and within 9 months with the same workforce, they became the highest quality plant in GM's, not only in all their plants. And one of the things he says is you can either change people's minds in order to get them to work in a new way, or you can have them work their way to a new way of thinking. And so some of the ideas we have in training people and getting them to work on projects within the clinic is they start to think differently. So I often say we work our way to a new way of thinking, and engaging them in problem solving. And I think that, to me, changes culture faster than trying to, communicate. I mean, you have to communicate, but communications and emails and other things don't tend to work as much as we provide, if you will, lean coaches and other things to get people, because in the end, doctors want to do the best for their patient. What you need to be able to provide them is some help to do that. And I think, and you have a champion, and we give them the tools, and I think what we found is that they step up, and they think differently than patient satisfaction, I have doctors now, they want to get patient satisfaction weekly. They want me to get tablets and they can get information in order to feed back how the clinic is working. And if you'd have told me that I would have people asking me that 5 years ago, I would have had a stroke. I just don't.
And been on Coumadin. I'd say that similarly, we focus on the patient. It's our culture from the beginning, our AHAcares.com that focuses and starts with what is best for the patient, both with service excellence and quality and care. And that's part of our culture, and to be able to spread that, all of our staff members and physicians go through a customer service program called The Customer. It's a national program that helps to focus not just on being nice, but really getting to the heart of what, serving people with what they want and need. And I think that's a big piece of it.
I think it's a great question, and especially in the hospital environment. You can put little fixes in place for every possible error that you can try to do, but there's too many things that can go wrong. And the evidence is really clear that it's the safety culture that I mentioned in my part of the talk, that increasing that can create much higher levels of safety across the organization than all of these little fixes that we try to put in place to deal with errors and near misses. What we found seems to work the best, it gets back exactly to what you said, Bob, is that it's hard to manage what you don't measure. And there is a survey for safety culture. By the way, there is one available. It's free of charge on the AHRQ website for physicians' offices as well. But we use the hospital-based one. We survey each unit at least every 6 months, and the lower performing units get checkpoints every month or two to see how they're doing, and we ask each of the local unit management to come up with plans to improve it. The most dramatic one that I've seen so far, we've been doing this for about 1.5 years, was in one area of our operating rooms where, as you know, the authority gradient issue that I talked about earlier tends to be higher in surgical areas, where surgeons are kind of up here and sometimes feel, the staff feel uncomfortable, and the safety culture measurement was the lowest I've ever seen anywhere by far. The surgeons were appalled by that and actually agreed to go through 360 evaluations where the staff would submit data, 5 or 6 questions about each individual surgeon. They asked for this, and we did it, and they got some very valuable feedback, and the safety culture scores in that area just skyrocketed. So that was the most dramatic, but we have seen significant improvement in most of our nursing units over time. We still have a ways to go, but measuring it, there's no substitute for that. And I encourage you to do it in your office, even with your staff. We got information that we never would have suspected, and the people would not have probably volunteered had we not done it by survey.
Thank you. I covered a few topics. I'd like to open it up to anyone who has questions. There's a couple of microphones centrally located. Step up and fire away.
One for Dr. Flanders. For years I have talked to Luz Rosenbaum with the M&M conference. Our M&M conferences are not M&M conferences. They're topics. We've never presented sentinel events. There's one sentinel event that occurred to one of my patients that I insisted be presented at the M&M conference, and it was. But by and large, we don't know any of the sentinel events because they're never presented to the staff in general, okay? Point 2, I'm a solo practitioner. I guess I'm a dinosaur. From the model that you guys present, you're talking about large groups with a lot of ancillary help, with receptionists and nurse practitioners and so forth. Do you see any role for the solo practitioner in the future? Now, I will tell you that 30 years ago, it was said that solo practice is going to go away. And then the next point is that I think that there's a problem in terms of medical education because I see junior students in my office once a week for 6 months. I see senior students daily for a month during their senior rotations. And the point that I keep trying to stress to them is making clinical judgments, as opposed to needing to get a test before they can make a judgment, before they can act on something. And they're trained in the hospital. And so they have no idea what it's really like in general practice or out. And then the other thing I tell these kids, is that the day you finish medical school, you're a doctor. The day you finish your residency, you're a small businessman, and you know nothing about being a small businessman. And some cursory little talk, 1 hour, is not going to teach them how to do that.
Those are great points. I only feel qualified to address the first one, though, Nick. I'm sorry. But the thing about the Sentinel events, you are absolutely correct. I completely agree. And actually, the holdup has been over many years, not just at our hospital, but at most hospitals, that the legal department would not allow us to discuss those things publicly. That has changed. But well, let me finish my thing. That has changed at Beaumont, and I apologize that it hasn't happened in M&M, but we are doing open town hall forums now on these cases where we bring hundreds of employees into a room and tell them about things that have gone wrong in the hopes of educating and preventing future events. We had a speaker in, a guy named Ridley Barron, and his talk is on the Beaumont website if you have access to it. Just an absolutely heart-rendering story. This is a guy that lost his child at a hospital in the South due to a medication error. So we're doing more and more of that sort of thing, but we need to extend it to the medical staff. You're absolutely right.
You want to deal with solo practice?
Yeah, I actually was in solo practice my first 9 years, and then had one partner join me, and then in '95 joined IHA, which grew from 37 now to 240 docs. So I've seen the whole spectrum. Solo practice was great. It was the ultimate autonomy. And again, back in the 80s with HMOs, I was able to affiliate through HVPA, our IPA, to get contracts to work and be, again, a service to a large number of patients. And there was an interesting article back in the mid-90s in Family Practice Management called Bicycling with the 18-Wheelers. And it was an editorial about the fact that, hey, somebody wrote in and said, hey, you guys keep talking about all these big groups and what they're doing. I'm in solo practice, and I like your magazine still, but can't you have something that justifies the fact that I'm still important to the system and the healthcare? And they answered it well and said, yes, there is a place for that, and I think there still is. And I think there still will be. It's going to become increasingly challenging, though, with the ACO and risk-taking, with increasing regulations and understanding and keeping up with all of that. Let me tell you, I don't see any of the new med students going into solo practice like I did in '85 anymore. And whether those who are currently in it and have enough of a practice, and at the IHI model, the sort of the micro practice version, which is heavily IT supported and integrated with each other, has been very successful if you go to some of the IHI conferences. So good question, challenging times, but there's still a place for you. You're not a stegosaurus.
As far as the students, I think there's been a significant move to move at least 50% or more of the training to outpatient settings. And I think because the hospital is a unique place to train, I think it is an intense place for students to learn, but it is the same level of testing or the same level of decision making is not needed or is different in the clinic. And right. I would agree with that for the most part. I think that's true. And so I do think that we've moved the curriculum, and we also moved the curriculum that includes patient safety, implementation science, and other sets of skills that they're going to need to be able to be the future physicians of the future in improving healthcare.
My only comment I guess I would throw out there is that, that's what UP is really trying to change in the way we work with all of our shareholders. And I think that some of these things you've heard about complex care managers, modern